right, welcome everybody to tonight's webinar. This is for the Society for the Study of Celiac Disease December webinar. I am Sharon Weston. I'm one of the co-chairs of the webinar committee for SSCD, and I am happy to introduce tonight's webinar topic on the Nutritional Assessment Project updates from the International Work Group presented by Dr. Ann Lee. And it is really an honor to welcome Ann to present this evening's webinar. Ann is an esteemed assistant professor of nutritional medicine at Columbia University and is a leading dietitian for the Celiac Disease Center there. She has a deep commitment to patient care and groundbreaking research. Ann's work explores critical aspects of living with celiac disease. Her research focuses on quality of life challenges, dietary adherence, and the nutritional quality of the gluten-free diet, offering valuable insights into how the rigidity of the diet impacts eating patterns and behaviors. Her contributions have sparked a paradigm shift in the education and counseling of individuals with celiac disease, and she is the lead author of a recently published white paper, which was a systematic review article titled Dietary Assessments in Individuals Living with Celiac Disease, Key Considerations. And relative to this evening's talk, Ann is collaborating with an international team of clinicians who met in Sheffield during ICDS to establish global standards for nutritional assessment, education, and dietary adherence in celiac disease care. And we are honored to have her share her expertise with us tonight. I'll stop sharing my screen so Ann, you can go ahead and share yours.
I need to send it. Actually, it seems like I need to send a request to you. Oh, here we go. Okay. Okay, well, it's an honor to be here and a real pleasure to share our work with everyone. What we're going to do tonight is to really go through the process of how we came to the white paper and kind of a look at where we're going from here. Here are my disclosures. They're just the working with the non-educational grants to actually produce this great work we're working on. So what we'll do tonight is when we think about, looking at where our pathway is going, is we really need to kind of look at, look at the gluten-free diet, kind of from where we started and where we are and where we hope to go. So we're going to describe the change in the diet over time. We'll look at the gaps and barriers included in assessment and looking at adherence. And really the goal today is to highlight the work that we're doing together to standardize nutritional assessment and management of celiac disease. So to kind of take a step back, and it's always fun for me to kind of look at kind of where we started. And when we think about the pivotal role of a dietitian in celiac disease and management of the gluten-free diet, it's good to kind of look back and say, gee, we have made great strides. And, for all of us that are working in celiac disease, it wasn't that long ago that we really didn't even know the trigger for celiac disease. It wasn't really till the 1950s that really the wheat was identified and gluten was identified as the toxin, or the trigger for celiac disease. And going from ancient Greece to the 1950s now to the 2020s, we can see that there's been a shift. We know it's an autoimmune response. We know that there's increased rates of diagnosis, increased awareness. We were just talking about the availability of gluten-free products, internationally, and how much that has grown over time. However, with this great advance in our knowledge about celiac disease, the advances in what we do with the gluten-free diet and our education around the gluten-free diet hasn't changed a lot. And the donut is there because we still, when you look at gluten-free products, it tends to focus on bakery items instead of a general nutritional diet. So gluten-free diet in the 50s, when we look at it, really focused on fresh fruits and vegetables, your naturally gluten-free foods. At that time, there really weren't a lot of products. Our role was really to help our patients figure out how to make that gluten-free bread at home, or try to bake some of those gluten-free options for their family members with celiac disease. So it really was a focus on what was available naturally gluten-free. If we fast forward to today, we see there are a plethora of products. There's aisles with gluten-free products that are dedicated, in many, many grocery stores. There are products that you can get from around the world in many grocery stores. It's really anything you would want in a gluten-free version, pretty much you can find it. And interestingly, even it's not just those dedicated gluten-free manufacturers that was the case 20 years ago. Now even our mainstream manufacturers have come into the gluten-free arena. But when we look at that, we have to remember that, there's so much about the gluten-free diet that's important, and we see the changes and the shift over time. But we really have to come back to that for someone with celiac disease, food is their medicine. And we really need to take a deep look at what that is that we're teaching our patients. So whether it's 1950 or today, the concerns on the quality of the diet and the adequacy of the diet still remain. A wheat-based diet is required by FDA law here in the States to be any of the wheat-based products to be enriched back to their natural state, which makes those products high in B complex vitamins, high in fiber, and high in iron. And when we take those wheat-based products out, that leaves the gluten-free diet with many nutritional gaps. In addition, the dietary products are not required to be enriched like their wheat-based counterparts. So we have some gaps in the diet. And when we look at many of the products that now line our grocery store aisles, we see that still to today, many of the products are based on starches, not whole grains. They typically use rice, potato, and tapioca, which are not as nutritionally dense as wheat-based products. And to try to mimic the texture and the taste of wheat-based products, there's a lot of added oils, sugar, salt, and many gums and things, which renders us, while there is a plethora of products, there's not great nutritional quality. So the nutritional quality has been noted in many different research studies. The landmark study by Hallert back at the 2002 rather, he really was one of the first that really identified that poor vitamin status in his patients that were on a gluten-free diet. And as he looked at it, he saw there was increased weight, poor nutritional status. But the only difference from the general population to his patients on a gluten-free diet were the numbers of bread servings that were being eaten each day. And he identified that that's where the nutritional gaps were. In 2010 with Valletta, he looked at pediatric patients, and again, many of the same findings. Our patients gained more than anticipated weight, actually pushing some of them from a normal BMI to a higher BMI. And Kabini and his group in 2012 found the same thing, that not only did we have increased weight, but we had increased weight into unwanted BMI ranges. In addition, a great study from Italy looked at the gluten-free diet intake by patients with celiac disease compared to population control, and found that although the total number of calories was similar across both groups, where the calories came from was very, very different. There was increased calories from sugar and from total fat in the celiac patients, and those total calories, when we looked further into the carbohydrate part of the diet, were based mostly in cereals and cakes. And interestingly, even in Italy, there was less of an intake of pasta than there was when we looked at the general population. And this just gives you an idea of that, where our patients are getting their calories from, what they're choosing to eat, and what foods they're replacing their wheat-based foods with. And so when we look at this, we see the diet is in transition. We need a new approach. And we know the only treatment is the gluten-free diet. But I think what we need to do, where there is a shift in knowledge, we need to have a shift in the treatment. We need to focus on the patient, not just on the foods we take out. We need to think of beyond what to avoid. We need to think of the diet and food as social in nature, that the quality of life is impacted by the diet. And there's been several studies that show the impact on families, on eating behaviors and patterns. And what we're going to do is look at some of those studies quickly to show you where that impacted our direction in developing the assessment paper. Because we know the impact on our patients is multifaceted. It's everything from availability of gluten-free food to the cost of food, to the ability to read labels, to the social impact of it. So from our research, we're going to review a couple of the studies that really, to me, were pivotal in framing how we look at assessment and how we look at adherence and what really drove our project forward. On one of the studies we did on hypervigilance, we looked at adults and teenagers and found that when we measured the degree of vigilance in our patients, those that were considered extremely vigilant had much lower, statistically lower quality of life scores than those that were of moderate vigilance or just adherent, versus those that were non-adherent, again, had poor quality of life scores, but it wasn't as much of a change from the moderate group. Interestingly, higher knowledge was associated with the lower quality of life score, and higher knowledge was also associated with feelings of limitations and increased frequency of checking labels and menus and questioning. And so these maladaptive behaviors really, teeter on disordered eating behaviors, and that really has us, worried about that crossroads and that crossover from, adherent behavior to eating disorder behavior. On the study where we then developed a study where we're looking at eating behaviors. In the review of literature, we found that females with celiac disease were 46% more likely to develop anorexia than were the general population. But we also found, in looking at the different studies, that it's really a bidirectional relationship, that there were many patients that have eating disorders that seem to be a little bit more likely to develop celiac disease, and we're not sure what that link is, as well as those with celiac disease developing eating disorders. And so we really want to look at, with our patients, the pathways that formulate those behaviors and to try to intervene before those eating behaviors get established. When we looked at the results from the adults, we're still working on our teen study. We found that, over a quarter of our patients actually met the clinical cut points for clinical depression. We found that 58% self-selected to avoid more than just gluten in their diet. They would choose to limit whether it's onions or garlic or dairy or, different foods without a recommendation by a physician or dietitian and without a diagnosed allergy to those foods. And that we also found that those that avoided more than just gluten without a prescription or a recommendation were more likely to be depressed than those that only avoided gluten. We also, from there, kind of looked at, well, how does this impact one's social life? And we looked at this and used our quality of life tool. We used a social anxiety questionnaire to see where this then impacts that social aspect of food and eating. And we found that in the age group from 23 to 35, they were more likely to have a clinical cut, they're more likely to meet the clinical cut point for social anxiety than those that were over 65. We also found that the length of time on the diet was also impacted quality of life scores and social anxiety. Less than 1 year, we found that there was less social anxiety. And we kind of think this might be a honeymoon period where, gosh, I feel better. I know I have a diagnosis that's real, compared to those that then were in that 1 to 4 years or 5 to 9 years since diagnosis, where the social anxiety around the diet tends to increase. We also looked at dating, and when we think of social life, we think of going out with others and things, and we found that those that were dating with celiac disease really felt that there was a major or moderate impact on their dating and social life. So how does that now form what we do? And we looked at, we know that we should be looking at all these different aspects. We should be looking at quality of life, environmental factors, depression and anxiety. But when we did a short study, just kind of a review of charts at Columbia, we found that we don't do a good job at looking at these things. And in fact, when we looked at these 40 consecutive medical records, we found that in tracking them, over a third of the patients never saw a dietitian or doctor after their initial visit, that 40% had one other visit. So we really, not only do we need to address these things, we're not following up our patients to make sure that we're addressing these problems as we see them going forward from the time of diagnosis. Additionally, we found that not everyone had follow-up blood work. And we found that, although there was improvement in some blood work, it really depended on how often they followed up. And we see that there's a need for a team approach to follow-up and assessment, where we really need the combination of the doctor and dietitian visit and all the lab work and making sure that people follow up. So that we find that in terms of, some other studies that looked at it, that, close to 90% in this study continued to follow up with a doctor over time, that only about 16% ever followed up with a dietitian over a 5-year period. And so that we need to really make sure that we're following the guidelines that were given by NIH and different groups to make sure that we are doing follow-up. And so when we look at, even the pediatric group, a chart review of close to 300 biopsy-proven children, we found that at 1 year, only, about 3/4 were following up. And that when we looked at follow-up in a 5-year time period, it dropped down to only 39% were being followed up at 5 years. And so this now kind of made me go like, well, we know we should be doing all these things, and the current guidelines for management from ESPGHAN, NASPGHAN, NIH all really lay out a beautiful follow-up and management protocol with inclusion of dietitian access and education, but we're not following it. And that was one of the things that really made me start questioning, what is the standard of care? Excuse me 1 second. And we know that the dietitian evaluation, is the gold standard for nutritional assessment. However, when we ask different dietitians what they do, there is no standard among that even dietitian evaluation. And in this NIH grant that we're working on now, it's a multi-center grant with 4 different celiac centers. We found that even the education of what the information we give our patients varies from hospital to hospital, even with the length of time per visit, the content of the education, how strict is strict, and even what foods are allowed, even though we would think that at this point in time, that would be a very standard thing. So these factors all really formulated our drive to form this nutritional assessment project. And really, it's not only to standardize the content and the assessment of our patients, but it's really to establish uniform guidelines so that we're all speaking the same language. When we look at our patients, we look at research studies, we realize we're talking about adherence to a diet or, persistent symptoms, but none of us are speaking the same language because we're not assessing our patients the same way. When we talk about adherence, what do we really mean? When we talk about persistent symptoms, what do we really mean? How are we defining? Are they related to a gluten exposure? Or is it some other component of the diet? And so the importance of this project is really to not just give us standards and guidelines, but to really shape the future of dietary intervention. So I think of it as really more than a project for building the future. And now we're able to really look at building the future internationally so that, when we look at our 4 sites, we realized, excuse me, I'm so sorry.
No, take a break.
Yeah.
But Sharon, do you kind of like between the pediatric hospitals, do you have some guidelines that you do with kids in general?
I think there is such a broad variety right now in terms of the way that dietitians assess and instruct our patients. I think that this is such a well-needed project that is going to help everybody, because even within hospitals, different dietitians don't do the same thing. So this is where this consistency of instructing and monitoring and following up is going to be so important. So, and you know, to do it on a domestic basis is the first step, but then international is going to be phenomenal. So yeah.
Well, thank you very much. I think I'm back and okay. Thank you,
Okay.
Emily. I needed that. But what we found is, as Sharon said, is that when we looked at the 4 sites of the main project, is that there was no consensus. And importantly, what was missing is that not everyone used the same clinical markers. Physical activity was often not even addressed. Symptoms were sometimes addressed, but left to the physician to monitor. And even intake was not always done the same way. And when we looked at the adherence tool, and we're going to look at that a little bit more in depth in just a moment, we found that there was really a lot lacking there too. So this was kind of what formulated the initial project. And so what we did is we formulated a team from the dietitians and the gastroenterologist at the 4 different sites. We did an extensive literature review, developed questions, developed topics, and we'll go into some more of this, where we met monthly from the start of fall 2021, formulated that list of topics. We also included concerns, barriers, what our patients' concerns were, what their questions were, and really asked our patients to really give us input on how does living with celiac disease affect you? Does the diet matter? And then we grouped by common threads different topic areas. We divided the topics up amongst the team, and each dietitian and gastroenterologist were then given a topic and asked to research and then present back to the team so we could formulate some decisions on topics. So the topics that we investigated were nutritional assessment, education, and adherence. And so specifically looking at, you know, what was included in that assessment. And not only what was included in terms of at the sites, but what should be included. We looked at education, and again, looked at not just what was being done, but what would be the gold standard of what should be done. And with adherence, looking at which tool should be used. So the educational background, you know, in formulating this, we realized, okay, we're going to look at assessment, we're going to look at adherence, but we also needed to formulate an education program. And to do that, we really wanted to make sure that we changed the process of diet education from one that's based on, here's a sheet as you walk out the door, to one that's based on an educational framework. So using the medical nutrition therapy 4 basic steps, we incorporated behavioral therapies, we incorporated a framework on stages of change, on social and environmental factors, and, you know, and really things that affect food choices, beliefs, and behaviors. So each session has 4 key parts where, you know, in kind of my educational background, it takes that back and says, okay, each lesson should excite our patients. They should explain and educate. They should expand their knowledge base. And then there has to be an exit or planning strategy so that they have goals for the next time. So in taking the educational background, we looked at the importance of incorporating this not only into the educational part, but into the assessment part, so that the patients understood why we're asking the questions we're asking and how that can form their decision and their behavior. And so it's really focusing on that we as healthcare practitioners need to understand the motivators, the social influences, and the environment of our patients. So the standard education that came within this model is 3 basic lessons and 3 supplementary lessons. The content of what was educated and lessons were all standardized with flexibility, knowing that each patient is different. And a great education plan is terrible if it doesn't fit the patient. So you have to have a basic plan that's adaptable and flexible enough that it can be adapted to the situation and to the patient. So we really, each one works on developing the motivation, identifying motivations and barriers for each patient, helping them develop strategies to navigate these barriers, and developing solutions with the patients, and then reinforce that in that necessary follow-up. So in developing the lesson plans, as you said, teaching points, behavior goals, and establishing goals with the patient. This is just a look at what that education program looks like, in terms of, we incorporated the basics, foods to eat to avoid, label reading, setting up a shared kitchen space, strategies for dining out, addressing potential barriers, navigating social situations, and then how do we follow that up? How to teach them how to negotiate with family and friends, how to navigate dining out with someone new or a work situation. A sample topic was cross-contamination, which is interesting. It really started with, the current practices. We had everything from the different sites, from you needed separate dishes and things to you needed a gluten-free shampoo, to you couldn't do Play-Doh, to yes, everything's fine. So we really needed to come to a consensus. And actually, even when we started discussing it, to define the term. Is it cross-contamination? Is it cross-contact? Is it chance exposure? So there's a lot of things that we really needed to get down to the nitty-gritty. And in doing that, we looked at some pivotal studies. There was a pizza oven study done in Italy that really, identified that you need a separate prep area and ingredients, but other things could be shared. It doesn't need to be in a different building. The study by Studeris that looked at, that cross contact within a kitchen, tested colanders, knives, wooden spoons, and found that as long as things are cleaned, there was no detectable gluten on those things. Key there is you can't let a 5-year-old wash a spoon and hope that it's good. You have to make sure things are clean. So we had lots of discussion like these and really hammered out, based on research and based on science, what was the best approach to include into this educational theory-based program. So a sample lesson is, that you would have a teaching point, the objectives, and then go over all the details to help them identify barriers, motivators, and things that need to be expanded on or reviewed. The final program ended up with 6 lessons and 20 handouts. It covered every part of gluten-free living that we could think of. And that's where I look forward to the next project with the international group, because I'm sure there's gaps in what we've done. And this said, we kind of came to this point then, said, okay, that's wonderful in terms of defining the assessment and follow-up. That's wonderful in developing the educational program. But how do we, really measure adherence? And we realized there's no standard protocol. And how do we measure adherence? Is it histological healing? Is it normalization of serology? Or is it absence of symptoms? And we really realized that, there's no consensus on even the definition of what is adherence. And so that alone poses a problem. In addition, there's no consensus on which tool to use. Do we use the CDAT? Do we use the gluten immunopeptide tools? What is it that we do? And so what we did is really looked at the different types of adherence tools that are currently available to us, and looked at the findings in terms of, in the different studies, how did these compare and what did they compare it to? And what we found is that no study, no tool really was compared to all of the same outcome measures. And so it really leaves us with some gaps, is that the CDAT was compared to serology and in biopsies, but then some of the other studies said, well, but there was no consensus even in the studies that compared the same measures. And so what we realized is that with this lack of standardization, we really said that, we need to look at what the adherence tool is really going to measure. And several long-term studies found that, when they used the adherence tool, about 75% rated that they had adequate adherence. and adherence proved with improved quality of life. And so we wonder is if there isn't a degree of improved adherence with improved quality of life, which comes from better education and knowledge. And so we looked at this and realized that the current tools don't look at motivators or barriers or self-efficacy or even perception of cost. And so we said, these are the things that are missing in the standard tools. So we're asking about knowledge and if someone ate gluten or where do they eat gluten, but they don't look at the reason behind it. So we started to develop a new dietary adherence tool, and we incorporated it into the nutritional assessment. And it's designed to be administered by both dietitians and research personnel. We formed a dietitian focus group. We went through many iterations of this tool and had external reviewers look at it, trialed it in clinical practice, reviewed again, had people look at it from outside of our site. And what we're doing now is we're actually going to use the tool in our current NIH U01 trial. It will be compared to the CDAT, which was the most commonly used tool that we found. It will be compared to villus architecture and serologies at the end of the study. So hopefully, as we go forward, that this will be a tool that will really try to capture all of those aspects of adherence that we need to. So all of that really was consolidated down into our review paper. And the final paper really identifies all of these things we talked about, but also gives us a guidance in terms of what should be included in the nutritional assessment, what knowledge and what information should be included in a standard educational program, and it has a draft of our new adherence tool. So from this, our future goals is we formed a network of international gastroenterologists, psychologists, researchers, and dietitians. We had our initial meeting in September at the ICDS, and we have started some of the basic work on developing work groups out of that. And we are working with a group to do a review of literature that would be very rigorous using the Delphi process. And our goal is to come up with standardized nutritional therapy for celiac disease, including the assessment, the education, monitoring, and adherence. And with that, I thank you for the opportunity to really go through all of this. And a really special thanks to my initial group. Amelie, you're part of this here, that without this group, this would not happen. So thank you. I won't stop there.
All right. Thank you, Anne. And I'm just going to share my screen again.
Yes.
All right. Right. So, so I guess we're going to open it up to questions right now. Certainly, doesn't look like there's any questions in the chat yet, but please feel free to enter your questions in the chat. I have a couple of questions, Anne. So, first off, there's so many differences when you look at this on an from an international perspective, right? So, what do you think are going to be the biggest challenges looking at trying to develop something consistent, but on an international basis where you have like so many different policies and food composition and training? There's just so many different things to think about in
There's so many
the different countries, right?
There are, because even the role of the dietitian varies greatly from country to country. And so based on that is, one of the things that we really want to try to have a standard that can be used as if you will, kind of the skeleton, and then have it with the group really adapted so it's culturally appropriate. So, but the standard, we still realize that we need that skeleton that is core to everyone. And I think some of that is, when we look at the big questions, is it's not often what's gluten-free and what's not, but it's what is available in New Delhi compared to Rio and Toronto, and just to name a few places. But how can we, really distill down the basics that everyone needs to have, and then adapt within those basics the culturally appropriate recommendations? In talking to my colleagues in India, where we think of let's make sure our grains are gluten-free, there that not only do they need to make sure the grain is gluten-free, but they teach their patients to actually buy grain, clean it, and mill it at home, because the manufacturing doesn't allow for it. So although we're still going to have the standard of make sure the grain is gluten-free, and then depending on where you are, if you need to mill it, because the manufactured milled product is not safe. So that would be, these are the safe grains, but then how you use them would be something that would vary from country to country.
Interesting. Just thinking about India also, not talking about the grains, but talking about the dietitians and the standard practice, and how many especially adult patients in India don't even really get to see a dietitian or follow up. And then a lot of, I think some studies have shown that the dietitians really didn't have a lot of knowledge regarding celiac disease, so just again, comparing that practice and how are you going to disseminate all of these standards of care and then actually get them across.
Well, my goal is, and I have some colleagues who tease me all the time that I'm always thinking on the next project. And my goal is really that if we can get that skeleton of standardization for assessment, education, and adherence, the next step is going to be to take that and then really internationally educate patients and educate our dietitians, so that no matter where you are, you have access to this information, and to try to increase awareness that way. We're lucky here in the States is that we have the academy, and even though the certificate of training may be a little bit on the older side and such, it's still a good basic knowledge and basic information, and it's available so that we can increase that awareness everywhere. And so my hope, stay tuned, in a year or two maybe we'll be talking about this, that what our educational programs are going to be, to then take what we have here and translate that internationally.
Yeah, exactly. The Academy's certificate of training is, the 5 modules, right, are something that anybody can do online, right?
Exactly.
So having that available on an international level would be amazing, right?
So great plans in the works.
Any other questions?
Yeah, hi.
Yeah.
Well, one, the chat is disabled, so that's why you're not seeing questions in the chat.
Oh, shoot.
But yes, hi, I'm Ashwin Agrawal. I'm a pediatric gastroenterologist at Robert Johnson, Barnabas Health, Rutgers. And I'm actually building the pediatric celiac program here. And we were doing the exact same thing we were discussing during this meeting. Meeting with the dietitians, the GIs, the pathologists, trying to standardize everything. Like yesterday, we just had a discussion, should we be doing the CDAT or what other survey? But my one question is, I love the idea of having, 6 lessons, but how do you fund that, right? So in New Jersey, many private insurances do not pay for RD visits for celiac disease. So it becomes a big out-of-pocket expense for some of these patients. Medicaid is different.
Medicaid is different. I know that at Columbia, we couple our dietitian visit with the gastroenterologist, and I realize not everyone can do that. But my feeling would be that if we have those 6 lesson plans to cover the basics and then supplemental. But that would be something that you know, as we're developing this and taking this internationally, our goal is to actually have these available, hopefully through SSCD or some of the other, organizations, that you would have then access to that information. That even if your patient doesn't have access to a dietitian, they should have access to some of the information. It would be better administered with a dietitian so they can really, do that full in-depth assessment, but no one should not have that educational information available.
That's great. And I was also wondering, is the Academy or SSCD doing any advocacy to try to get celiac disease as a covered diagnosis for medical nutrition therapy?
Yes, the Academy is, I believe that some of the other patient-based organizations are working on that. It's something that we've been working on for many, many years.
Okay, thank you.
Thank you for your question.
And to follow up on that question, I know that some pediatric centers, especially in Canada, will offer like group class instead of like individual consultations. So do you think that your lessons could be applied to a group setting and not an individual setting?
Absolutely, they can be. Ideally, you want to, really individualize it so that you're addressing the individual patient, nuances. However, the basic information could easily be covered in a group class. And then anyone who would be able to have individual consultation, that could be in addition to that basic information. As the gentleman before just said, it's one of those things where we need to get that basic information to our patients so they have the right information and they're not using Dr. Google to find out things.
And I had a different question. It's so interesting with the and a bummer, but with the increased rates of depression, and I'm just wondering if that has ever been correlated with dietary quality.
That's a great question, Sharon. And I really, there's been a couple studies looking at the degree of processed foods and ultra processed foods our
Yep.
patients are consuming. And it's actually frightening how many of the gluten-free products fall into that ultra processed category. And diet quality is something that we do need to assess. And within the lessons, we have a whole lesson on really focusing on naturally gluten-free foods, using the naturally gluten-free grains instead of some of the highly processed foods. I don't think anyone studied the link between the two yet, but I think it's something that, needs to be on our agenda and radar to look at.
I see that Michelle Cullen raised her hand before to ask a question.
Yes. Can you hear me?
Yes.
Okay. So I've been teaching this diet a long time, and I know we need to individualize it, and I do. I do individualize the education, but a lot of it is very, very repetitive. So I'm going over the same thing with different patients. And I'm just wondering if there might be some way to to create a series of lectures for patients to view on their own that go over how, cross contact, and go over, how to avoid cross contact, dining out tips, like some of the things that you talk about over and over, because, that takes a lot of time too. And I find that I'm spending a lot of time, with that first session. It's really a big crash course, but there's so much that I can't do in that first session, and I can't always see them again, or I might see them a couple months later. And, time is an issue, for educating these patients. I mean, if six lessons sounds great, but like, I wouldn't have time to do 6 lessons for every new diagnosed patient, and then follow-ups too, so I mean, if I did nothing else, maybe.
Michelle, you're absolutely right. The 6 lessons are actually developed to be taught over time. And again, that's based on the ideal that we actually will get to follow up with our patients as all the guidelines recommend. Our hope is that we're going to keep pushing for advocacy and keep pushing for awareness. But to Emily's point before, some of those basics could be covered either in a webinar, in a video instruction, or in a group class, which would then, make it easier to then take those individual concerns each patient has and address those concerns. The idea again is to have a basic framework, and then we need to adapt it, and it is the good counseling takes a long time. And so we recognize that.
And it's not just my time, it's the patient's time. Everybody's so busy these days. Like people just want, tell me the basics, tell me the most important stuff quick. Just like get to the point, and
Right.
it's, you try to do that, but it's, there's so much more you could talk about
Yes,
and
yes.
should.
Right. And that's where, again, kind of, to emphasize a point of the need for, standard in follow-up care, because what a patient needs when they're initially diagnosed versus what they need 1 year after diagnosis, and then through the different stages of their life, whether it's transition to college, getting married, having children, each of those stages of life also presents different topics and different needs and different questions. And that's where we need to really work on our advocacy, that patients need to be followed over a lifetime.
Okay, thank you.
You're welcome.
I want to add also that I think that your point about the group classes is a great point, because so at Boston Children's, we have so many kids diagnosed every week. So we have a new gluten-free class held every week, and it's held at different times of the day and different days of the week, and it's there's always a number of families in each class, and that seems like it's a very effective way to just have that hour and a half session to
and cover all those basics. And see that's a great example of how this can be taken and adapted. I know that Nick Trott over in the UK has also looked at the efficacy of having group classes in terms of, to Michelle's point, the dietitian's time and the expense of it, and some insurances will cover a group class where they won't cover individual instruction. And so that we have to look at all those possibilities, but we all need to say this, we all need to be talking the same language though, too.
Yes. Yeah.
But these,
by Zoom, you can have, it's so much easier for working parents too, if they, or anybody, Zoom just makes things so much easier. So.
Absolutely. And was there a question?
I was just asked if there was, if it was done in person, or if those group classes were done in person, or if they were done via telehealth. And I think Zoom, somebody said Zoom, so.
Yeah. Yep. During COVID is when they started going by telehealth instead of in person, and the attendance has really gone up. So
Good.
yeah.
Great.
I think Lillian had a question.
Yeah, you noted earlier in your presentation that like higher knowledge was associated with hypervigilance. I was wondering if you kind of thought there was like a sweet spot, so to speak, with patients of knowing enough to be adherent to the gluten-free diet, but maybe not knowing too much that it becomes more of a worry to them.
William, that's a great question, and we actually want to go back and look at, that question again, but then to really dive down into it didn't seem to be gender-based. It didn't seem to be age-based. It seemed to be associated more with knowledge. But what we want to look at is there, what are the other factors that are associated with it? Are there other behaviors that are associated with it? And so to really look at, its lower quality of life, but what some of the qualitative responses we got in our questionnaire was that they felt that reading all the labels was time consuming, that having to check labels was time consuming, and that it was embarrassing to ask the questions they felt they needed to ask when they were dining out. And we think that those kind of things are probably the leading impact and effect on lowering quality of life. However, we know it's like each time we do something, we know that we have 10 more questions we need to answer, so that it will continue to evolve. But I think that in addition to just more knowledge, we have to look at what about that increased knowledge that's affecting behavior that is then affecting quality of life.
That makes sense. Did you happen to see like any age differences as well, maybe as like diagnosed as kiddos versus adults, the knowledge aspect?
We didn't do that, but that's our next part.
Okay. Yeah.
That's something we're working on. And actually, even within the eating behavior, we looked at our adults in terms of quality of life and social behavior and different things. In our kiddos, what we're doing is actually looking at their quality of life, the adherence, anxiety, depression, but we're also looking at the Big Five personality inventory, but we're doing it in the kid and one parent. And I think that that will be very, very interesting to see if some of these behaviors and attitudes that we see in our kids is affected by the adult parent. And I think that that will be a very interesting thing to look at too. So that we're starting to dive in and say, okay, what is really affecting some of these behaviors, and what is it that's triggering more depression or more anxiety? And all that will help formulate where we go from here.
Awesome. Thank you.
You're welcome.
In creating your, kind of consensus, did you find a quality of life survey that you liked? Like there's a couple that come out every few months. I think the most recent was like the CD Life I saw that assesses like 4 domains. But is there one that your center is using routinely?
What we've used routinely is the CDQOL, which has been kind of our standard. I have to admit, we developed it, and then our team also worked on the pediatric version of it. I know there are a couple other ones that have come out recently. My goal would be to actually use some of those in addition to our CDQOL in another study to really look at them comparatively and see if any of the newer ones that are coming out capture more of these behaviors and attitudes that we may be missing in our CDQOL.
Great, thank you.
Absolutely.
Well, thanks, Ann. Any other questions? All right. Well, I am so appreciative of this talk, and I think that it's just going to be such a huge help in terms of just providing better care for our patients on an international perspective. So thank you, Ann, for all your work.
My pleasure, and my thanks to the organizers, because without you guys, we would not be able to do this and spread the word. So I thank you deeply. It's been an honor.
All right. And so our upcoming webinars for SSCD are going to be in February and April. And so look forward to some notices that will announce those and save the dates. Most of the webinars are recorded and posted on the SSCD website for our members. And feel free to keep up with SSCD by checking out our website, which is listed here. And I would just like to thank the SSCD webinar committee that's listed here, as well as the SSCD Council. And just in terms of joining SSCD, please spread the word. Membership is open to medical, scientific, and allied health professionals, and there are many benefits to belonging as a member to SSCD. All right, and I would just like to close for tonight's webinar. So thank you, everybody.
Thank you very much. All right, bye-bye.
Thank you, Anne.